Good morning. I'm Mairéad McNamara. I work at the Christie NHS Foundation Trust in Manchester, United Kingdom, and the title of my talk today is Whispers Over My Shoulder, and I will now explain why. My disclosure is that I'm a medical oncologist. I treat some patients where cure is a potential, and some where the goal is to control disease and not cure. I attended the annual Cholangiocarcinoma Foundation conference last year in Utah in 2019, and I thought it was one of the most memorable conferences I ever attended. There were many reasons for this. I had attended lots of sessions, and there was one particular session that stood out for me, and this was the poster session. I was standing in conversation with a number of different people, and there was a lady speaking to a man. She then discovered that actually he worked with the pharmaceutical company who made the drug that she was on, which had given her great quality of life and had extended her survival significantly, and she hugged him. When looking at all the talks on the patient perspectives and the family perspectives, there were two themes that I thought stood out for me. And these were those: patients driving their own care and empathy. As I said, during the day, there was patient perspectives and family perspectives, and I thought it would be important to have a physician perspective on these themes also. So the first I will concentrate on are patients driving their own care. So when a physician sees a patient, we always work on the evidence that's available, so best evidence. There are a number of recommendations and guidelines that we follow. So here is an example of one: the National Comprehensive Cancer Network Guidelines, or the NCCN guidelines. So this is just one example for how you would work up a patient with intrahepatic cholangiocarcinoma once they're first seen. And as you can see, there is a lot involved in workup. Then post-surgery, again, there are many different things to consider. Then, in terms of neoadjuvant treatment or adjuvant treatment, so adjuvant treatment would be treatment that's given after the patient has surgery. We have different options, with standard of care now being adjuvant capecitabine. In the advanced setting, so this is where cure is not an option, standard of care chemotherapy would be gemcitabine cisplatin, but there are other recommended regimens as seen here. But what is very clear is that there are many shades of grey. So when a patient comes to us and speaks about alternative therapies, and sometimes we might be skeptical, and this is because they're not in the available guidelines, and there isn't always the evidence to back up their use. So when we see a patient, what we do is we determine a number of different things. One, we talk about the clinical history. We find out how did the patient present. We look at the blood results for that patient. We look at the imaging, and we look at the result of the tumor biopsy. But this alone does not make up the full jigsaw. Other things to take into account are the patient performance status, any other health issues or medications, what the patient wishes are, and what the expectations of the patient and their family is. So then we get closer to having a complete jigsaw. But again, every patient is different. So when a patient is seen, the 1-year survival based on this recent study of over 1,000 patients that were included in first-line advanced clinical trials for patients with biliary tract cancer who received systemic treatment or chemotherapy. The 1-year survival recorded was 41%. However, what happens when a patient reaches 1 year or 2 years post-inclusion in a trial? What is their survival? This had been an unanswered question. So from this study, where there was 1,333 patients included, we found that at 1 year, the 1-year survival for those patients was 37%. At 2 years or 24 months post-registration on the clinical trial, the survival was around 45%. Then at 3 years or 36 months, it was 61% and then 63%. So the longer the patient survived, the longer the 1-year survival was. And the factors that were prognostic for this were things like receiving combination chemotherapy or combination therapy, and having an intrahepatic cholangiocarcinoma diagnosis or cholangiocarcinoma non-specified. So the other point, the other theme that had come across that I want to give some physician perspective on is empathy. This is quite difficult because the physician response to death is different for everyone. For those that have persistent exposure to death, they can develop some professional detachment, and this can be seen by patients and families as the physicians appearing cold or uncaring. But this is a way that some physicians deal with this because they are persistently exposed to this. However, stress and grief are universal and interrelated. So this is experienced by patients, families, friends, and their treating doctors and nurses and healthcare professionals. Every physician is different. They will have a unique psychological composition. They will have different established self-belief, and they will have different ways of dealing with patient death. And so everyone's experience is going to be unique to that person. When I was researching this talk, I looked online at available books that might help. Here was one that I came across, and it was called About Death from a Cancer Doctor's Perspective. The things that came across in this were about anger, fear, denial, frustration, and about the question, how can I cope with it all? This may help those who are trying to deal with this, whether it be a patient, family, or a doctor. Interestingly, when I looked up this book, just on the bottom right-hand corner, there was an icon saying add to wedding list, which I actually thought was a little bit strange as a wedding gift, but it may give new meaning to the expression, till death do us part. There was a study done in 2 Boston hospitals looking at the physician experience of patient death. And what came out from this was that the most emotionally charged experiences of death could be categorized in 3 different areas. 1 as a good death, 2 as an overtreated death, and 3 as a shocking or unexpected death. So these are the things that posed most memorable for physicians. When thinking of good deaths, I think we all can recall some of these. I think what happens is you do develop a heightened sense of hearing. You hear the person's breathing. You hear muffled coughs of other people in the room. And you hear whispering from outside the door on the corridors. And you nearly always hear, and it's often a single bird singing as day becomes night. I'm just going to impart some wisdom that I have, I suppose, learned over the years from patients that I've seen throughout my career. The first saying that I'm going to talk about is, health is a crown that the healthy wear, but only the sick see. So when I was a fellow in Toronto, my dad underwent surgery and I flew home over a weekend to see him. When I entered the hospital, in the entrance, this sign was inside the front door. And I have always remembered it. And I think you will always remember walking with someone that potentially was quite unwell. You walk slower because they just don't have the energy to go any faster, and they don't have the breath. Recently, I dealt with a GP, and one of the things he said to me in clinic was, "Why not me?" This has resonated with me also, as I think everyone knows that cancer doesn't differentiate. The last saying I have here was something that someone said to me recently. They said that it actually doesn't matter what you do or say, it's how you make a person feel. As doctors, we're often telling bad news, and when we're with the patients, we know that what we're going to tell them will be devastating for them, and that can be quite upsetting. One of the other cases that I'd like to share with you was of a lady that I saw when I was in my early medical oncology training. And she did say to me, "Have no regrets." So when thinking about that, when you're dealing with people close to the end, I think that one of the things is they never regret the work that they didn't do. They regret things with personal interactions or with family. So it's important to remember that. And I think this saying is quite important by C.S. Lewis. You can't go back and change the beginning, but you can start where you are and change the ending. I would like to leave you with this saying from Leo Varadkar, who's the outgoing Taoiseach in Ireland. He came out with this saying recently, and I thought it was quite moving. And he said, "Never forget what we've lost, what we've learned, and what we've gained." And I think throughout our careers, that's really important, as all the patients we have met during that time have been teachers, and we bring that into a clinic consultation every time we see a patient. And remember that we actually are all waiting in line, and everyone's day will come. So it is really important to make the most of every day. Thank you all for your attention, and I'm happy to take any questions.